Good afternoon, everyone, and welcome to our webinar today. Just to go over a few logistics, all participants have been muted. If you have questions or need technical help during this call, please utilize the chat function in the bottom right corner of your screen. You can also private message me, Desiree Smith, or Jennifer Mon, who's serving as our technical assistant. We are both listed as hosts. All questions for presenters will be addressed at the end, but we will keep a queue, so please send them our way as they come up. This webinar is being recorded. The recording and presentation slides will be emailed to those that registered. These materials will also be placed on the NCSD website. And as I was saying, welcome to our webinar, everyone, the impact of COVID-19 on sexual health services in the South. Again, my name is Desiree Smith, and I am the Health Equity Manager at the National Coalition of STD Directors. We have a few objectives that we would like to cover with you all for today's webinar. Those being, our first goal is to focus attention on COVID-19's impact on sexual health, of course, including interruptions on COVID-19 barriers, broad interruptions to STD and HIV services, sexual health clinics, and then secondly, COVID-19 and PrEP and PEP, and then its impact on initiation and retention of PrEP, and then impact on access to PrEP and PEP as well. Although our country has been affected by COVID-19, the southern United States has significantly felt its impact, with southern states currently making up about a third of new cases. Southern leaders in HIV prevention are working tirelessly to ensure that not only ending the HIV objectives are met, but to also innovate new methods of delivering HIV prevention services during the COVID-19 pandemic and beyond. This webinar will discuss how southern jurisdictions are feeling the impact of COVID-19 on sexual health and HIV prevention tools such as PrEP and PEP. And to begin, I would like to welcome Mara Michniewicz from Florida Department of Health.
Hi, thank you, Desiree, for that introduction. I appreciate that, and thanks everyone for being on and for this opportunity. Can you hear me okay?
Yes, we can.
Excellent, wonderful. All right, so we were asked to provide just a little bit of information on COVID impacts to our HIV and STD services in our state. And so today we'll be talking, and I have with me some amazing colleagues. I have Dr. Jeffrey Beal, who is our HIV section medical director, and I also have Dan George, who is our STD program manager, and he'll be filling in for Mr. Craig Wilson, who is having some connectivity issues. So I'm happy to have them both here presenting with me. Both have over 30 years experience in their respective fields of STD and or HIV, and are extremely knowledgeable and a wealth of information. So thank you both as well. So as I mentioned earlier, we're going to be talking about some interruptions to STD and HIV clinical services. We will highlight some data for you, specifically about STD field investigations, interviews, overall STD services in our health department clinics. I'll briefly discuss, and maybe Dan will as well, some information on the modifications and interim guidelines that we sent out to our county health department field staff for both HIV and STD field services. And then lastly, we will finish up by talking about telehealth services, specifically for PrEP, so PrEP telehealth services. Before I continue, I wanted to just mention that the Florida Department of Health is an integrated health department. So we have a state health office here based out of Tallahassee, where Dan and I are. Dr. Beal is located in Lee County, but he works for the central office as our medical director. And so we have 67 county health departments that all basically follow the lead of the central office or the state health office here in Tallahassee. So when we issue interim guidance, that goes out to all the county health departments. and it is implemented and put to use either by our STD or HIV program managers at the local level. So first, I guess I'm going to switch the order up just a minute before I have Dan speak about the STD Field Services modifications and the data. But in general, when we realized early on we had specific services and methods of doing things that were not conducive to the COVID restrictions that were put into place shortly after, I want to say it was about March 13, 14. So in most cases, when conducting field investigations and or linkage to care for HIV, working with clients, phone use was somewhat limited, only because in our Department of Health, phones were considered not secure, especially cellular telephones. So landline phones were considered secure, but it was the cell phones that were causing us some issues. And so our leadership in our department worked with our DOH information, or Department of Health, information security manager to basically put out a memorandum, I believe it was around March 25th, that basically granted exception to the rule about not using cell phones. So in this particular instance, there really was no other option, and we needed to continue providing this level of service specifically for HIV and STD field investigations and HIV linkage to care. So we were really very pleased with the memo that was sent out far and wide to all of our county health departments. It was sent out department-wide, so it went to everybody. And so it basically allowed for the use of cell phones with the understanding that confidential information should only be discussed in areas where conversations cannot be overheard by those without a need to know. So that was one really helpful memo that went out to help us with our work in the field. And then secondly, we had another memo that went out to all of our health officers, nursing directors, medical directors, STD managers, HIV managers, our disease intervention specialists, regional linkage staff, TB nurses, TB field managers and coordinators, and then all county health departments. That was basically interim guidance on communication for both communicable disease investigations and linkage to HIV care during the COVID-19 pandemic response. So this memo provided interim guidance to all the county health department staff to ensure that they were still communicating with patients served by either HIV, STD, viral hepatitis, or TB control programs. And this guidance within this memo really only applied while social distancing guidelines were in effect. And so we elaborated a little bit on the use of telephone, and we talked about what steps should be taken prior to disclosing protected health information, or PHI, by phone. So we wanted to just lay it out very clearly because we were getting a lot of questions from our field staff because they were very used to doing things a certain way, and they didn't want to jeopardize patient confidentiality in any way. So we provided the following information to ensure that, to maintain confidentiality, before you initiate a call with a patient, we want to make sure that you're in a secure environment where no one can overhear your conversation. It's important that you share the employee's name with them. You identify yourself as an employee of the Department of Health, include your location, and you make every reasonable attempt to confirm the patient's identity and let them know that important health information needs to be shared with them. So really the other piece of this is ensuring that you're speaking to the person that you intended to speak to. So it was important to try to confirm the patient's identity by obtaining at least the following information. So the patient's full first, middle, and last name, including any suffixes, their date of birth, and at least one of the following pieces of information. So they may not have had all of these things, but at least one. So either the name of the testing facility and the date of the exam or test that they had done, their social security number, and or a driver's license number. So one of those three things, in addition to their date of birth and full name, was required to confirm that, yes, you are indeed speaking to Jane Doe. We also wanted to make sure that if the phone, if they were using a cell phone, that the patient was informed of that, and advised that cell phones weren't considered a secure method of communication, meaning a third party could intervene, because that is a possibility when using a cell phone. And then asking the patient if they were in a physical location where they could communicate confidentially and privately. And then last but not least, obtaining verbal consent from the patient to disclose the information to them by phone. And disclosing that information, meaning test results. And I know that there are some state health departments that have been doing this for a long time via phone. I mean, off the top of my head, I know Washington State has allowed their disease intervention specialists to provide results and do this work over the phone, but traditionally in Florida we had not. But this particular instance, during the COVID-19 pandemic, this really pushed a lot of policies in a different direction, and I think that, moving forward, this is a good thing, and hopefully we can maintain these changes and just enhance them, and maybe we can change the way that this is being done on a regular basis. Lastly, I said obtain verbal consent from the patient to disclose that information to them over the phone, and then the field staff would then document the information with the consent date and any notes regarding the conversation. Secondly, this particular memo allowed for, which had not been done previously, but allowed for texting and Facebook Messenger to be used to basically prompt the patient to speak on the phone. So that was the caveat. So not using texting or Facebook Messenger to share this confidential information, but using the texting and Facebook Messenger to basically initiate contact with the client and let them know that you have a need to speak with them on the phone. So the memo indicated that personal health information, or PHI, must never be sent via texting or messaging, and then to limit the disclosure of PHI, our staff must use only the template messages provided below. So within the memo, we actually provided a script for field staff to use with clients if they were contacting them via texting or Facebook Messenger. And, they were pretty straightforward. My name is so-and-so. I'm with the Florida Department of Health, and I have information regarding an urgent health matter. Please call me at, and then you would provide the number. If they didn't respond, you could again say it again. I would still like to speak with you regarding an urgent health matter, and then provide the number again. If the patient responded to a text message with another text message instead of calling, we also advise them to use language like this. So, I'm not able to give you specific information in text message or email. Please call me at, and then provide your number. Or the information I have for you is confidential. I can tell you more when you call. Please call me at the following number. So, it may be a little different for some states that have been using this this method of communication for field work and release of confidential information. But for us, this was a new step, and I'm glad that we took it, and I'm glad that we afforded our field staff this information. I will let you take over in just a second, Dan. I was just going to speak briefly about some of the interim guidance that we provided to our HIV field staff, specifically around a couple topics. So the first one was linkage to care. We basically incorporated these two memos into our guidance for our HIV field staff. So the linkage staff, again, were used to using a landline, to call clients and or actually doing field visits, so locating the client and then speaking with them in person. So we were able to provide our linkage field staff with this information that, yes, you can use cell phone to communicate with the client, and two, yes, you can be using texting and Facebook Messenger to basically prompt the client or to let the client know that you need to speak with them, so as another way of trying to locate a client. We also instituted some COVID-19 checkboxes, and I'll explain what that means. So we have a linkage module where we basically track all linkage activities and linkage records that our field staff are working. And this is also how we get out our data to care list and assign those records to staff to then work. But we kept hearing from staff that, I can't get in touch with this person, I can't locate them, and so there were some instances where it was obvious that the COVID-19 impact was having an effect on this. So we added some checkboxes so that Linkage field staff could indicate that it was impacted by COVID-19, so that on the back end, when we were able to run these records and we're able to see how many of these linkage records were impacted by COVID. So we added a COVID-19 checkbox and said that for any record that's closed during the time which was unable to locate or link as a result of COVID-19, that's what you would check, so that when we went back to look at why that record was closed during that time, we could see that, it was because of COVID and or COVID presented a barrier for linking this client. We also added a telehealth checkbox, and Dr. Beal may touch on this later, but during this time, as you can imagine, the request for and the need for telehealth significantly increased. So we added a telehealth checkbox in our linkage module to indicate that clients who were either unable or apprehensive to attend an in-person medical appointment for HIV care initiation, they were offered telehealth. And so we wanted to be able to document that in our linkage module. So by adding this box, we could then go back and look at, this client was, yes, linked to care, but it was a telehealth visit. And then we also provided information on the outcome of that telehealth visit. And then we had a reason for telehealth in a drop-down list. So we added COVID-19 as one of those reasons, so that now, when we go back and analyze those data, we can see just how many records were impacted by COVID, how many clients may have opted for telehealth because of that as well. We also added test and treat to our drop-down list for options at the county health departments and also non-county health department healthcare settings. So those are used for clients who initiate care through our test and treat program. And test and treat in our state, it's the same as rapid care initiation, so immediate linkage to care. Let's see. In addition to that, we provided a little bit of guidance around ensuring persons receive their HIV test results. So first and foremost, in our Florida statutes, it says we have to make every attempt possible to give someone their HIV test results. Again, we incorporated the memos that were sent out into this because traditionally we don't share that information by phone because it's not always secure and it's not always possible, or there's apprehension about verifying who you're speaking to over the phone. So we, to ensure that people were getting their results, we instituted what I spoke about before, to ensure that you were confirming the patient's identity by obtaining at least the following sets of information: name, date of birth, and then at least one of the following pieces, meaning where did they test, what was the date of your test, or your social, or your driver's license. So that was provided as well. We indicated that, if face-to-face PrEP services were still possible, to go ahead and do that. If not, we were able to offer the option of telehealth visit to initiate PrEP services. We, at the time, I think we suspended HIV test site registration in our state. We have a site registration process. The sites want to register with the Department of Health. That usually requires an on-site site inspection by our field staff. And so during the time when everything was on lockdown, we had advised them, if your local health department is currently not allowing you to go out, that's fine. We'll just halt that for the moment. And then for HIV testing, again, all of these guidelines were issued to our county health departments with the following statement, that we still think you should deliver essential services. However, they should be delivered at the discretion of the county health department and based on the current situation, staffing levels, the local county health department directive, and any executive orders that were released related to COVID-19. So some of our counties were more impacted than others. We obviously had counties that had really high numbers of COVID and some that did not. And I will say that we had, on the non-health department side, we had plenty of community-based organizations that never closed their doors once during this time and continued to provide services. So it really was a mixed bag about, how much each site was impacted. So, Dan, I'm going to stop here, and I'm going to let you speak a little bit about Std Field Services, any interim guidance that was issued, and then if you'd like me to move on to your data slides, I'm more than happy to do so.
Okay, thanks, Mara. So I guess the short question is, what didn't happen in STD prevention in 2020? I mean, what a year. So I just wanted to give you an overview of our STD organizational structure in Florida. As Mara said, we are centralized. We have roughly 200 STD program field staff. Of that is about 140 disease intervention specialists that are within our 67 county health departments. And during 2020, we had numerous field staff infected with COVID. We had entire teams in major programs like Miami, for example, that were quarantined for 2 weeks. Other staff were being pulled for extended periods to work COVID contact tracing and other duties. So we were being pulled in 100 different ways, as everybody around the country was, I'm certain. In April, everything pretty much came to a screeching halt. Virtually all of our DIS in the state were grounded from conducting field investigations, which we were really, certainly very nervous about because we thought that at least if you can do priority investigations, find that woman who has untreated syphilis or find that woman who is HIV positive and not in care. So we worked very diligently with our county health department and area STD managers to say, do you have at least one person that can do field investigations? So we were working case by case, county by county, making it absolute priority. But like as Mara said, because field investigations were largely grounded by county health department directors, we came up with some interim guidance. And, it's not in our best interest to be doing interviews and we're making referrals over the phone and cell phones and all like Mara alluded to. But, you have to do what you have to do. The important thing is to get mom treated for syphilis and get her into care. Those kids, 13 to 15 years old, they are our priorities. So we have had lots of competing priorities in the year. For the year 2019, Florida reported about just under 165,000 cases of bacterial STDs, chlamydia, gonorrhea, and syphilis. In 2020, it dropped by 10,000 to about 154,500 cases. Interestingly, the big drop of that was chlamydia. We saw an 11% decline in the number of chlamydia cases from over 111,000 in 2019 to 99,000 in 2020. Interestingly, gonorrhea increased by 8%. And guess why? Because gonorrhea more often is symptomatic. And so folks were still seeking services because of a discharge or what have you. And we feel that, chlamydia dropped by 11,000 cases because females weren't going in and getting routine screens. Our syphilis morbidity remained relatively the same, just over 12,000 cases. And, despite all of our challenges in 2020, we still, over those 12,200 cases of syphilis, exactly 80% were treated within 14 days of the lab receipt date. So, and that's one of our goals, and we actually met that regardless of, not doing field investigations and staff being pulled. So, really, we're so very grateful to our STD program field staff for maintaining as best they could in that kind of situation. Mara, do you want to go ahead and put those slides up? Okay, So you can see we had a significant decline in the number of Std Clinic visits. Number of clients went from 93 to 69,000, a 25% reduction in overall clients seen. Clinic visits to our Std clinics in the state dropped by over 26%, and overall services provided dropped by almost 30%. You can see the table to the right is the number of field records assigned to our DIS workforce by year. You can see with HIV, it declined by 15%, so there were 28,266 HIV field records assigned to our DIS in 2020. Syphilis dropped not as much because morbidity remained relatively constant, so that didn't really change much, but our DIS worked over 80,000 records. Chlamydia, we're basically just verifying the morbidity, and we're not really following up on private providers to determine treatment unless we know mom is pregnant. Same thing for gonorrhea. But you can see decreases across the board. Next slide, Mara. Is there a next slide? Okay, here you can see the number of interviews conducted by our DIS workforce. Not a big drop in HIV, a little greater drop with syphilis. And chlamydia and gonorrhea, I said we have 111,000 cases of gonorrhea in 2020. We interviewed 2,900 of those. Our criteria for interviewing chlamydia is kids under 16 years of age and women who are pregnant. So that's why our numbers are very low in comparison to the overall morbidity. So I guess that's about all I have, but it's been quite a year. We actually had, I know of 2 DIS who succumbed to COVID. One of our DIS in Jacksonville was one of our recent year winners of the Tommy Channer DIS Excellence Award, which we award one award each year to the best performing DIS in the state. And that's all, Mara.
Thank you so much, Dan. I really appreciate you doing that. I know Craig does too. All right, so continuing on, I'm going to touch on just a little bit about HIV testing, our in-home HIV test kit program that was actually launched pre-COVID, but then took on a totally different meaning post-COVID, and then just a bit about PrEP. Then I'll let Dr. Beal chime in regarding our PrEP telehealth visits that we saw in 2020. But first of all, just to touch briefly on our publicly funded HIV testing program. So we have had in Florida a publicly funded testing program, confidential testing program for a very long time, so probably since 1986, I'd say. And we have over 1,400 registered HIV test sites in the state of Florida. If a site wishes to present itself to the public as a place where someone can receive an HIV test for free and in a confidential or anonymous manner, they're required to register with the Department of Health. As a registered HIV test site, we are able to provide our sites with indirect support in the form of test kits. We can also assist our sites with lab processing at our state public health labs. We have 3 of those in Miami, Jacksonville, and Tampa. And so in our testing network, it includes a whole bunch of different agencies, right? So we've got our county health departments, we have our community-based organizations, we have correctional sites, we have outreach sites, substance use treatment sites, all sorts of different sites. And many of our sites conduct more activities than just HIV testing. Most are conducting testing, community engagement, linkage outreach. Many now are conducting PrEP and NPEP as well. On average, publicly funded HIV testing, and when I say publicly funded, traditionally we're using funds provided to us from CDC in the form of our HIV Prevention and Surveillance Cooperative Agreement and or state general revenue funding. So on an average year, we conduct between 310 to 340,000 publicly funded HIV tests annually. So this figure here, the orange bars in 2019, you can see on average, we were conducting about 26,350 HIV tests a month in 2019. The blue or teal bars, I think you can see for yourself that they took a steep hit in March and April. So we saw a significant decrease in March and then an even more severe decrease in April. So on average in 2020, I want to say that we were conducting just over 15,000 tests a month. So the decreases were pretty big in March and April, but then we entered May and June, and we saw a little bit of promise and hope, and we noticed that, levels were starting to go back up. Unfortunately, I think you can tell for yourself that they aren't quite back up to the level that we were at pre-COVID, which was, again, around 26,350 tests a month. So all in all, I would say that after, we just did our upload to CDC of our 2020 data, and, I think the decrease just approximately is almost close to 60%. I think part of this was also due to the fact that we weren't able to collect the same level of data from our HIV self-test kit program that maybe we would have liked to, and I'll talk about that in just a minute, about some of the reasons why, but anyway. So this is publicly funded testing. You can see the COVID impacts, and on the next slides I'll show you, you can see that the data, they follow the same trend with, a decrease in March, and then it's even more noticeable in April for other services. So I'm just going to speak briefly about our in-home test kit program for a second. Beginning June 1st of 2019, we launched from our knowyourhivstatus.com website, and that is the URL right there. We launched our in-home rapid HIV test kit to individuals to receive a free test kit mailed to their address of their choosing. And we are currently using the OraQuick in-home rapid HIV testing kit. I think most of you are probably familiar with this kit. If you walk into most retail stores, so CVS, Walgreens, Walmart, Target, you can also purchase this kit on your own. It retails for approximately $45. Some stores may sell it for less, some may be more. You can even order it online if you Google. So there's a couple different options. But the whole intent of this project, and of course pre-COVID, I'm sorry, I forgot to update that data bullet at the bottom. We've actually distributed over 3,000 kits to date. But just to touch on this, so pre-COVID, our intent for the in-home rapid HIV test kit program was really to ensure that persons who would not test otherwise had an option, right? So folks who didn't want to walk into a county health department, or people who were not comfortable going to a community-based organization, or people who didn't want to go to an AIDS service organization, or people who just honestly didn't want to have any interaction with anyone else. They just wanted to get the kit themselves, take the test kit into their home with all the privacy they desire, and do it that way. And I think that and maintain that anonymity as well. I think that means a lot to a lot of people. So I can see how this would be appealing to a lot of folks, myself included. I think that a lot of people feel this way. So individuals who request a test kit through this online portal, basically they would complete a brief, short kind of pre-test survey, because one, we need your information to mail the kit to you. So we need your name and a valid Florida address. So at first when we launched the program, we said you had to be a Florida resident, and then we revised that to say you need a valid Florida address, and you can interpret that how you want, but either way, we need a valid Florida address. So that, along with some basic demographic information, was collected on the front end. So gender, sex at birth, race, ethnicity, and age. Of course, this is all self-reported, and we don't necessarily have a way to confirm that. Now, I will say that the OraQuick in-home test kit is only approved in individuals 17 years of age and older, and that's per the manufacturer's standards, so we could not send the kit to anybody under those ages. Our survey was available in English, Spanish, and Haitian Creole, and so the kit is mailed from our office to the requester, along with linkage to care and PrEP information. We also included information about our HIV/AIDS hotline that we've had in place in our state for many years. It's not just a phone line, but users can also chat online anonymously. And so that the hotline's also available more frequently than the health department staff, are in the field. So if anybody, perhaps wanted to call or we're in distress, they could call the hotline and speak to a crisis counselor if they so choose. In addition, after the kit is mailed, our staff here from our central office follow up with an email to the link where the requester can voluntarily provide post-test information and actions taken. So I know many states embarked on the HIV in-home test kit program long before we did. We actually worked closely to get some best practices from both Virginia and Arizona. They had some really robust in-home testing programs long before we did, so we tried to learn from them and build from them. But we didn't have the capacity to provide incentives for the post-test survey, and I know that is somewhat detrimental to your post-test survey response rate. So that's what I meant earlier about not being able to collect quite the level of data that we had wanted, and I think now that CDC and others are asking for. So the intent of the program was never to replace traditional testing, but as a result of COVID, I think that's kind of where it went. The in-home test kit program initially was launched as just another option for folks to be able to access testing if they didn't want to access it via traditional means. So now we're having to rethink a little bit more if we're able to get additional information. We also would need to present it this way, I think, on the website and let people know that, we may be asking you additional questions. We may be asking you some questions that might make you uncomfortable, that are a little more personal. And then on the back end, after you get the test, someone may contact you. So we've heard from our community-based organizations in the field that, in fact, that's what some of them are doing. So prior to giving a client an in-home HIV test kit, they may be trying to collect more of the risk information that's required by CDC on the front end. And then afterwards, after they get the test, then following up with the client via phone call to ask them if they're willing to share their test results. So that's the tricky piece here is trying to get that result from that rapid test, albeit a preliminary result, but still it's important to know that. So we're having some conversations here about some ways we can look at the data from 2020. So perhaps, and again, it's over 3,200 kits actually for 2020. So, of those 3,200 individuals that received an in-home test kit in 2020 via this link, can we do a match maybe, on the back end and see if any of those individuals then were prompted to get a confirmatory lab test, which if that confirmatory lab test were positive in our state, that's a reportable condition, and that would be sent through our HIV surveillance system. So that might be one way to look at it and see, of these individuals, were we able to get any sort of information about the test results. But that was our in-home test kit program, and that's just a picture right there of what it looks like on the page. Again, it's on the knowyourhivstatus.com webpage. The actual landing page for that site has two options. One is to type in a zip code to find a test site near you, and now the second option is to request a free at-home HIV test kit. And we do, well, I guess we might need to change it since we're Florida residents, but again, Florida address, that's what we need, a valid address, preferably, because sometimes the kits will get sent back to us, return to sender type thing because the address wasn't inputted correctly. So that's a key point too. Make sure it's a valid address. And here's our numbers. So again, you can see that it was very meager to start out with, January, February, March. And then right after March, we started seeing some significant increases in the number of kits being requested. July obviously was the highest month. That month, that's not just requests, and I have to keep noting that because you're like, wow, that was a really big month. That particular month, we actually did a send-out to several of our agencies and some county health departments with an allotment of the in-home test kits so they could use them locally. So that was why July looks so very high. And I'm going to move on here. Dr. Beal, I'm going to talk briefly about the number of county health departments receiving PrEP prescription. And you know what? It doesn't have my PrEP telehealth visit slide in there, but I will talk about it. And then if you have additional information to add, I will turn the mic over to you. But this particular slide here is speaking about the number of county health departments clients receiving PrEP prescription in 2019 versus 2020. So in Florida, as of December of 2018, all 67 of our county health departments have the ability to counsel and prescribe PrEP to clients. It's similar to a PrEP drug assistance program where we pick up the cost of the medication, so the client receives the medication at no cost to them, and they can come back and request refills as well, also at no cost. We also instituted a way to help cover labs and in some cases clinical fees, and we know that that traditionally is not able to be covered with CDC HIV prevention dollars, so we had to look to some state general revenue funding to be able to cover those costs. So in 2019, we had over 3,200 county health department clients initially prescribed PrEP as compared to about 2,600 in 2020. So we had almost a 20% decrease in the number of prescriptions during the same time period for both years. And Desiree, I have a box that popped up and it says nothing is being shared. I don't know what that is, but guess I'll ignore it. I don't know. Nope, it just moved, so I don't know what it's doing. So back to the PrEP prescriptions. Oh, there it goes. It went away. Thank you. I don't know what you did, but you made it work. So on average, in 2019, we were averaging about 270 clients a month receiving PrEP prescriptions, and then in 2020, that dropped to about 220 clients a month. And again, you can see for yourself the visual is pretty clear. Our 2019 bars in the blue or teal, and then the 2020 bars in orange, with the decrease beginning in March, and then the most significant decrease occurring in April. But again, back on the upswing in May, June, and then July through the rest of the year, it fluctuates a little bit, but doesn't drop as low as it was in April or May. So that was good to see. And I apologize to everybody. I did have a PrEP telehealth slide, but what I'll do is I'll just mention briefly what we saw. So similar to the other slides that you've seen for both PrEP prescriptions at our county health departments as well as HIV testing, we saw the largest increases in PrEP telehealth visits occurring in May and June, with the average monthly telehealth visits remaining higher throughout the rest of the year, throughout December. So we experienced, so going from April to May was almost 130% increase in the number of telehealth visits. So it was definitely significant. And the reason, obviously, was the COVID impact and people having that apprehension of coming face-to-face, coming into clinics, for services. It was a little bit concerning for them, and so we wanted to make sure that our county health departments were ensuring clients know, and, Desiree, don't worry about it. It's okay. It's really okay. She was trying to pull up that slide for you guys. It's really okay. No worries. I'm almost done. I'm going to let Dr. Beal take over in just a minute and provide any anecdotal evidence, because he was the lead for the telehealth team and really helped get telehealth on the forefront, basically, as a service that the county health departments could provide. So, Dr. Beal, I'm going to pass the mic to you if you have anything that you'd like to share with this group about, prep telehealth visits, but telehealth in general, and kind of how we use that during COVID and now kind of what we're seeing moving forward, and the fact that telehealth is great and a lot of clients want to use it.
Thank you, Maura. You did an excellent job already of covering everything. I do want to share with the group that we did have a telehealth program primarily for our test and treat program, which is rapid initiation of antiviral therapy for patients who are newly diagnosed with HIV or needing to return to care. It actually began in February of 2018 with two full-time practitioners, one APRN and one PA, and then in my role as medical director on my state days, I provide backup for the overflow of services. With the advent of COVID, the STD section took lead on pulling together support from county health systems for an expansion of telehealth services that would also now include the care and the treatment of persons with sexually transmitted diseases. And through their lead, we actually developed a telehealth web-based site for the education of the 67 county health departments on the availability of telehealth, how to access telehealth, and somewhat of an advertisement that we were here to help when people are deployed or not available. So COVID actually launched the telehealth program across the health departments, bringing it a higher visibility, which has been a tremendous benefit. We use for the platform either Microsoft Teams or we use Doximity. There is a new program coming about called TechZip that our TV program, who's done telehealth for many, many years, is transferring to, and they're exploring now possibly moving our telehealth program to that platform. They're HIPAA compliant, they're confidential. We did have the same restrictions on phones utilization and telehealth with an attorney statement read to patients asking their verbal permission for us to be able to provide their services through telehealth. But to give you an example, for the 17 months of the telehealth program from February of 2018 through July of 2019, we saw a total of 499 patients, but from January of 20 through December of 2020, we almost completely doubled. It went up to 955 telehealth patients, and that's for all services. We do a rapid initiation of HIV care, antiretroviral therapy. We do PrEP, and we do NPEP services through telehealth, and now we do STD treatments through telehealth on demand from county health departments. There was a tremendous impact of COVID on all of our county health department personnel. Most are deployed giving shots with a skeleton crew at quite a majority of our health departments. So having the ability to access a dedicated team of individuals has been quite popular. From a standpoint of patients, I would have to say that the patient satisfaction is extremely high. We've done surveys of patients as far as satisfaction in telehealth services. We rarely ever see a negative comment. The only disadvantage we've had with telehealth services has been when patients don't have adequate bandwidth for internet connections. That occurs in a lot of our rural areas in the state of Florida, or they don't have enough minutes on the phone or an adequate cellular connection to use their smartphones to be able to connect. That occurs probably in less than 5% of all of our telehealth sessions, where we have to revert from a visual to just an audio-based means of communication. Patients like not having to wait at the doctor's office, not having to drive to the doctor's office. We're almost always on time in telehealth, interestingly. Being as busy as we are, to be able to flip from one patient to another without having delays is primarily because of the teamwork of the excellent team and the admin that we have, who watches constantly for an on-demand request. And that's basically what I wanted to convey, Mara, so I'm going to close my comments and see if there are any questions.
Thank you so much, Dr. Beal. I really appreciate that, and I'll leave it open. I'll pass it back to Desiree, I guess, and I just wanted to say our contact information is on the last slide. And again, I want to thank a huge thank you to Dan George for filling in for Craig Wilson. Dan is our STD program manager in the STD and viral hepatitis section, and so thank you again.
Thank you so much. We really appreciate you all from Florida Department of Health presenting today. I want to again thank all of our presenters. Before we jump into our Q&A section, I would just like to alert everyone to our DIS Slack workspace that we have over here at NCSC. Slack is the communication platform of NCSC's DIS community of practice, where you can chat with DIS across the country and share resources on any topic from field safety to technology and partner services. If you'd like to join Slack, you can use the link that is in the slide deck here, and I can also post that in the chat box. And without further ado, we will now be taking questions from the presenters from the chat box. So please feel free to submit your questions there if you haven't done so already. Alrighty, if we do not have any questions at this time, just as a reminder, this is the contact information if you would like to reach out to anyone at the Florida Department of Health. With that being said, thank you all so much for joining us today, and that's a wrap.
Thank you.